Good evening.
Good evening, sir.
So, just
Yes, sir.
who are going to answer today?
So me and so Dr. Yasir is also there. Sir. Yasir.
Yasir. And
Yes, sir.
third one is also there, na?
So I'm not very sure about that, sir.
I'll ask a Tanvi. Manoj is there.
Okay, sir.
Manoj from Patna.
Okay, sir.
Oh. So you all have got the junior residents?
No, sir. Actually, they are yet to join, sir. They are yet to report.
Sir, are you able to see my slide, sir?
Yeah. But
Yes,
the first title is in what is hydronephrosis.
Yeah. Okay, sir.
Huh?
So that's
That
fine.
we are
Sir.
correct. I think we can see. That's not
What
a
I have done, sir, today is I have taken 7 cases.
Oh, fantastic.
We will discuss some aspects of each case.
No problem.
Rather than taking one particular case of say megaureter or ectopic ureter and continuing it for a long time, I thought the small parts of different cases. So hopefully we try to cover a good number of.
In 7 cases, important things which are, we have already in different cases, we have already covered quite a lot of theory. So now what is required is that in exam, they should have a quick thinking. See, unless and until they see multiple cases, they will not realize, because we don't know what type of case, what type of complicated case or multiple diagnoses they will get it. So what you are doing is best. Different cases, short cases, ask them particular questions and then go ahead.
Correct.
That way it will be good.
Yes, sir.
So just this time, how many seats were there overall?
So overall for DNB, I think there are 220 seats, sir. I think 220 seats for DNB. MCH, I think same number, sir.
So total about 450 seats.
450 also. Yes, sir. Yes.
Okay.
So our 2 candidates are yet to join. One is from they are yet to report. I think the reporting is still 14. That's why they are yet to report, sir. They're not yet reported.
सर इस स्पीड से तो कुछ साल बाद लेफ्ट किडनी के लिए एक यूरोलॉजिस्ट, राइट किडनी के लिए एक यूरोलॉजिस्ट, एक राइट यूरेटर के लिए, एक लेफ्ट यूरेटर के लिए, एक राइट टेस्टिस, एक लेफ्ट टेस्टिस, एक ब्लैडर के लिए हो जाएगा. इट इज
No, but sometimes this is little hilarious, but sometimes it is good. Like, in robotic radical cystectomy, we have made a group. So I do radical cystectomy. Then oncosurgeon, robotic surgeon comes. He will do ileal conduit. Before that, our another colleague will do total lymph node dissection because he is expert. and he goes all around right up to common ilia. Okay, and that's a fantastic. So we get rest. Ileal conduit is made. I go do reimplantation of ureter, and then he brings out. So all of us are doing little work, and we are free, and we don't get tired. No? So that is what is now required, like a teamwork basically.
गीते सर गुड इवनिंग.
गुड इवनिंग सर.
सर लास्ट टाइम आपको बड़ा मिस किए.
या बहुत मिस किया.
एक्चुअली थोड़ा सा सर ट्रैवलिंग में था लास्ट टाइम.
ओके.
गीते सर का क्या है कि he has got fantastic knowledge.
Yes.
And he has got a right approach, like that when everything is over, whatever theoretical part is left, he will just cover it up.
सर आप लोगों को एक एडवांटेज क्या है कि आप लोग एग्जामिनर्स हैं सर. हम तो कोई टीचिंग इंस्टीट्यूट से अटैच्ड ही नहीं है, तो एग्जाम हमने तो लास्ट मेरी MCH DNB एग्जाम के बाद आई हैव नेवर अटेंडेड एनी एग्जाम फॉर दैट मैटर.
No, so now I want to make this only that all good teachers, they come here and at least they take one clinics for the students, and
यूजुअली
get a good opportunity.
कुछ डिफरेंट नहीं रहते सर. एग्जामिनर रहा नहीं भी रहा तो एग्जामिनर रहा या नहीं भी रहा तो क्वेश्चंस आर यूजुअली 90% सेम ही रहते. जस्ट पर्सनल वेरिएशन 10% रहता है.
सर बस वो क्वेश्चन पूछना वैसे भी आसान काम है.
इसीलिए we have made a rule कि क्वेश्चन पूछो तो आंसर भी दे दो, so that you have to read and come. You cannot say I will ask you question, you find out the answer. So and my student was asking me that in a mock exam what should I read. I said do nothing, just ये जो clinics किया है सब 2-2 घंटा का clinic, रात को तू ये 10 दिन में every clinic you just listen to it. Most of the practical points and theoretical points are covered.
Yes.
So like today you are going to teach them in these 2 hours, whatever you teach them, most of the answers are there. So when they see the pediatric case, they will be able to answer. So this is what is required. And by reading, all these answers are not there in a book. They are given, but you may not be able to understand.
अभी तो सर ये स्टूडेंट्स दे रीड कैम्बेल सो मच इवन बिफोर दे जॉइन MCH और DNB, क्योंकि वो एंट्रेंस के लिए लगता है. ओनली थिंग दैट आई हैव ऑलवेज फाउंड इज मेरे पास ये जो MCH ज्वाइन करने के पहले कभी कभी आते हैं 1-1, 1.5-2 महीना काम करने के लिए स्टूडेंट्स, या सम ऑफ देम कम आफ्टर दे हैव फिनिश्ड इट. इट्स द application of what they have read.
Yeah.
And last time also I think Ojas you were there.
Yes sir. Yeah.
I remember asking you कि यार तू कौन सा एंटीबायोटिक देगा.
Yes,
this
sir.
is exactly so.
Yes, sir.
होता है कि you read a lot and then the confusion starts कि यार कैम्बेल का आंसर दें या जो रोज पढ़ते करते हैं वो आंसर दें.
Yes sir.
गीते सर आपकी आवाज नहीं आ रही है, कट रही है बहुत.
Ojas, your colleague Yasir is answering, na?
Yes sir. Yasir is answering. Yes, he has joined sir. Yes, he has joined.
He has already joined, na?
Yes, he has joined.
And who else is answering? I say.
So Manoj from Patna, Dr. Manoj from Patna.
Manoj has joined.
Yeah, he has joined it seems.
We'll just wait till 9. Normally we started by 9:10. So we'll just wait for 5 minutes.
चलेगा सर.
That we get a little good forum so that they don't miss anything, nothing else.
Sure.
Because now the exam, this is the last one. This is an exam going. All of them, only 2 months are left. So they are all under tension. Correct, Ojas?
Yes sir. Yes.
So after theory, then we will find out what type of examination is going to be there, and whether there are virtual cases or whether actual cases, and what are the questions. and we will decide whether OSCE is there or not, and then accordingly we will do. Fine.
Yes, sir.
We just wait for 5-6 minutes and then start.
Good evening, Pankaj bhai.
Good evening, Gyanendra.
Good evening, sir.
Good evening. कैसे भाई?
Pankaj sir joined from Nepal or India?
नहीं इंडिया इंडिया.
सर पीएम को पूछना ही पड़ता है अभी कहाँ पे हो.
अभी तो ड्रेस भी पीएम वाली है. कुछ नहीं यार, had a very tough day.
अरे.
Got stuck in one traffic jam for 2.5 hours.
That was tough.
So, yeah. I just reached home. और मैंने कहा अभी सिर्फ आपका ज्ञान गंगा में थोड़े डुबकी लगा ले हम भी.
सर बस आज ट्रैफिक जैम में कोई मिला नहीं तो हम ही मिले.
देख, पर सच्चाई तो ऐसी बोलनी पड़ेगी ना.
सर जाने तो पीएम से आर्गुमेंट नहीं करते, यस बॉस ही बोलते हैं.
और बताइए भाई, हाउ वाज योर डे?
Sir, quiet. Surprisingly, Tuesday was quiet.
Mm-hmm.
I was interestingly free quite early.
Mm-hmm.
So thought कि I should be home by 7.
Mm-hmm.
But वो destiny में रहता नहीं है.
Mm-hmm.
पहले एक एनेस्थेटिस्ट ने फोन किया, उसके रिलेटिव आ रहे हैं, थोड़ा सा कोलिक है, क्रिएट 4.5 है, देखो. The person had massive यानी bilateral pleural effusion and tachypnea. So he had to be shifted to an ICU.
Okay.
तो वहां से भेजो. दूसरा आया जिसको मैंने ट्रीट किया था 2013 में, और उसको आज दोपहर से इतनी गिडीनेस है कि ही कैनॉट इवन स्टैंड. तो बोले लास्ट टाइम तो आपने ट्रीट कर दिया था, इस बार क्यों नहीं कर रहे हो?
ये तो बराबर है, उसको कंप्लेन कोई वाजिब है.
वो तो ये चक्कर में इन दोनों ने 45 मिनट ले लिए, फिर अपने वापस रूटीन टाइम पे ही आते हैं, और क्या.
You know, I have a feeling that whatever work is there, it expands in the time that you have.
Yes.
And it is impossible कि आप टाइम से घर पहुंच जाओ.
Correct.
And आज कुछ नहीं था तो I got stuck in traffic jam for 2.5 hours.
Yeah. And suppose you end up coming early, वो आपको हॉस्पिटल से फोन आते रहते हैं, ये हो गया, वो हो गया, ये हो गया.
चलिए ज्ञानेंद्र, मैं थोड़ी देर मेरे साइड का ऑडियो बंद करता हूँ. आई हैव नॉट हैड माय डिनर. मैं ऑडियो वीडियो बंद करके सिर्फ आपकी बातें सुन रहा हूँ.
ओके.
बाय.
Ojas, you belong to which place?
So I'm from Mumbai only. Right now I'm doing my DNB urology at Kokilaben Hospital. Sir. Yes, sir.
You people must not be aware of the difficulties or problems that are there in the peripheral part of Maharashtra.
But now if you go to see, like in Miraj, he has built a now 350 bedded hospital. Yeah, that is a great thing. So now no more, now is a small town, is all the facilities.
It is not a question of the facilities available, it is the question of the infrastructure and its problems. You people never face the problem of power cuts.
Correct. So you have to have your own generator and
everything, sir.
Yeah, logistic, lots of problems are there. Water problem may be there.
Sir, पानी तो हमारे यहाँ 4 दिन में एक बार आता है. So if it extends beyond 7 days, then there is a raising of eyebrows. Otherwise, once in 4 days, people have got used to it.
Gyanendra, these are all problems which are manageable. The major difference is the mindset of patients.
Yeah.
So the expectations that they have from you at that place vis-a-vis what they have in Mumbai is completely different.
Yes. Yes.
पंकज भाई congratulations. कभी जा रहे हैं?
अब मैं कल सवेरे
Tomorrow you are going?
tomorrow, yes.
Oh, how many days? 3 days?
I'll be back on Sunday.
Oh, great. And you'll be talking on?
Sir, Holep.
Fine.
So one day I'm spending with Sanjay Khadgi.
हाँ.
और बाद में 2 दिन conference, 1 दिन थोड़ा सा sightseeing and back.
Oh, good.
Gaurang sir, Nepal has a holiday on Saturday. So Friday is a half day, Saturday is a holiday, Sunday is the first week.
Mumbai Urology Society.
All the 3 candidates have joined?
Yes, sir.
Ojas?
Yes, sir. Yes, I think even Dr.
Manoj has joined?
Yes, sir. I can see him as.
Is he unmuted?
Yes, sir. Yes. Good evening, sir.
Okay, good evening. So, shall we start or want to wait for 1 or 2 minutes more? Dr. Gite is there, ready?
Yes, sir. I am there, sir.
Okay. So then, can we start?
I'm ready from my side.
Okay, we wait for 2-3 minutes and then we start.
Yes, sir.
Welcome to I Get Music. I can do anything.
I think we should start now.
Yes, sir.
Fine, sir.
Huh? Because people will join, they are all busy. So exam going also. Okay.
Yes, sir.
So, shall I share my screen, sir?
Yeah, please start. Gite sir, you also please ask question in between.
सर गीते सर तो पूछना ही चाहिए.
Yeah.
Sir, you are able to see the screen? Yeah.
Yeah.
Yes, sir.
You can make it a full.
Yeah, made it full, sir.
No.
It's visible, sir?
No, it is visible, but it's not a full screen. And
Sir, I have made it full screen now.
so in that, you may be able to see. Anyway, you can continue. Start.
Sir, just a second. That would make things easier.
Slideshow mode.
तो slideshow mode में ही है. Are you able to see that?
Yes, we can see what is hydronephrosis. The first question, we can see that.
Yeah, यानी first slide is seen.
Yeah.
Yes, sir.
Full screen. Okay. We start with Ojas.
Yes, sir.
Ojas, how would you define hydronephrosis?
So dilatation of the pelvic calyceal system of the kidney, secondary to a distal obstruction,
Right. Now,
either function or anatomical.
right. Now, this has been a standard definition, dilatation of the pelvic calyceal system. But if you adhere to this particular definition, every hydronephrosis is secondary to obstruction. And then every hydronephrotic kidney should be dealt with by surgical intervention. So the correct terminology is it's hydronephrosis is dilatation of the renal pelvis and calyces. It's not related to obstruction. So the correct terminology which is now propagated is urinary tract dilatation.
Okay.
Now this is the first case. A 1-day-old baby. He has just delivered today. He is referred to you by the obstetrician.
Yanendra, your slides are not moving.
Shall I? Is this seen, sir?
Yes, sir. Yes, sir. You can see.
Yes, it is seen.
If I'm making it as a slideshow, then it is not moving, sir.
Acha.
8 seconds slideshow.
Because slideshow never happened for us.
Yeah. Now, are the slides moving now?
No.
No. Okay. Then now the slides are seen.
Yes, the slide is seen, but not in slideshow mode.
No, not in, because the moment I make it in the slideshow mode, the slides are moving from my end, but they are not being seen by you.
Okay, fair.
We stick to this.
Right.
Right. A 1-day-old baby is referred to you by the obstetrician. He is a male child having left-sided moderate to gross hydronephrosis on the prenatal obstetric scan. This is the information which has been provided to you by the obstetrician. What will you do, and are you happy with the information given by the obstetrician?
So first, I would like to ask about whether that 1-day-old is a corrected age, or whether that is whether it was full-term pregnancy or whether it was premature delivery.
It's a full-term pregnancy.
Full-term pregnancy. Whether the child cried immediately after birth, whether it was normal delivery.
Yes, all it's a normal delivery. All other parameters are perfectly fine.
Okay, Apgar square and everything was normal.
Absolutely normal.
Okay. And regarding the prenatal scan, also I'd like to ask about whether there was oligohydramnios or
no, there was no oligohydramnios.
Okay. And previous history of the mother, as in whether there any child with other any disorders at birth or any siblings? No, nothing.
First child.
First child. Okay, sir. and any other.
Oligohydramnios in the solitary means one side obstruction.
Yes, sir.
Do you expect oligohydramnios when only one side is obstructed?
So yes, sir, we could expect. Yes, sir. We can expect.
Solitary kidney, then we can
Solitary
expect
kidney.
Yes. Fair, go ahead.
Yeah.
So in this case, I will first try to put an infant feeding tube. So this child is male or female, sir?
Male child.
Male child. So I will try to insert an infant feeding tube and see how far the tube goes and whether there is urine being drained or not, and then accordingly.
Why do you want to pass a catheter?
So to see the patency of the urethra and the lower tract, sir.
But why are you worried about the lower tract now?
Because the patient has.
Are you happy with the information given by the obstetrician? You asked a lot of questions pertaining to the amount of amniotic fluid and other things which were present. I would have preferred you asking, what about the right side? Left side is mentioned. What about the right side?
Okay. Yes, sir.
And when you mention moderate to gross hydronephrosis, what does that mean? This is a very subjective description, moderate to gross hydronephrosis.
Yes, sir.
And this is exactly what happens most of the time, that the obstetrician will call you up saying कि उसको gross था या moderate hydronephrosis था, and अभी क्या करना है? There is no oligohydramnios. Where was the question of suspecting a lower tract obstruction?
Yes, sir. Okay.
So
plus we should
thing
ask,
that, yes, sir.
Plus, sir, we should ask whether the single sonography was done or serial ultrasonography was done to judge if the hydronephrosis.
So if the third trimester scan is mentioning hydronephrosis, what I would have asked is, one, what is the status of the right side? Was there any associated hydroureter? And thirdly, when they say moderate to gross hydronephrosis, it makes no sense to me. Either they should categorize it by saying AP diameter or by SFU grading. Okay, Yasir, can you mention what is the SFU grading for hydronephrosis?
Sir, in SFU grading, we have 4 grades. In the first grade, there is barely urine leakage into the sinus. In the second grade, there is dilatation of the renal pelvis. In grade 3, there is dilatation of renal pelvis as well as the blunting of the minor calyces. But there is no parenchymal disruption in this grade. And in the last grade, there is dilatation with this change in the major calyces plus change in the parenchyma. That's parenchymal disruption.
Right. Are you aware of any variations of the SFU grading system?
Sir, some have added, the latest has added, there are 5 grades. So
who has added?
In some books, 5 grades.
There is another grading system which is not very often followed, but if you have answered all this, if you are asked, there is a grading system by Onen. Onen's grading system is present. This is the SFU grading system that you have described. Okay, so grade 1 is urine barely splits the sinus. Grade 2 is full pelvis, major calyces are dilated. Grade 3 is uniformly dilated minor calyces, but the parenchyma is spared. And grade 4 is parenchymal thinning has happened. But traditionally, like SFU grading, the Americans tend to follow quite a lot, but traditionally it's if you ask most of the obstetricians who would diligently do a prenatal ultrasound, they would tend to rely more on the renal pelvic epidiameter because that would be a more accurate or objective evaluation of the hydronephrosis. Can you categorize prenatal hydronephrosis on the basis of trimester specific scale?
Amit,
So what is mild, moderate, and severe in first trimester, second, third trimester?
Sir, in the second and third, I know. In the
Yeah,
second
in the second and third.
mild is less than 4.
Okay, Yasir,
Sorry, sir.
let me ask
Sorry,
you
sir.
something.
4 to 7, 7 to
Yasir,
10.
Yasir,
and
just a
greater than
second.
10.
Yasir, you said you know it only in the second and third trimester. Why not in the
Second,
first trimester?
First and second is same, sir.
Second and third, I agreed. What about the first trimester grading system? You said you don't know. What is the first trimester?
This is a so in the first trimester, actually, it is a mesonephron which is functioning as a kidney. Whereas in the second trimester is the metanephrosis form, and that's why the urine is produced.
Very correct. So when does urine start producing? When is
After
the urine?
20 weeks, because that before that is a
12
mesonephron.
weeks.
12 weeks, yes.
It's after 12 weeks. So you
12
don't
weeks.
get an idea before 16 to 18 weeks at all.
Yes, sir.
Yes, sir.
Yeah. So what is this grading of ANH based on trimester specific scale?
In the second trimester, the mild is 4 to 7.
Yes, sir. Can you come closer to the mic? It's difficult to hear what you are saying.
In the second trimester, the mild is 4 to 7. Moderate is 7 to 10, and severe is greater than 10.
Yeah.
And in the third trimester, it is 7 to 9, 9 to 15, and greater than 15.
Yes. This is mild is 4 to 7, 7 to 9. Second and third, moderate is 7 to 10, 9 to 15. And severe is more than 10 and more than 15. Okay. Now, once this child presents to you with hydronephrosis, what is your worry? Obviously, the worry is fear of infection and deterioration of renal function. First question, when would you advise chemoprophylaxis in such patients? Anybody? Yasir, Ojas, or Manoj? Anybody? A child, an obstetrician has referred to you with prenatally detected hydronephrosis. It is epidiameter is more than 15 millimeter in the third trimester. Would you start chemoprophylaxis or you won't start chemoprophylaxis?
In the postnatal periods, I will do the ultrasound again, and I will see what is the grade, and on the basis of
when would you do an ultrasound postnatally?
If it is one side, I will do after 48 hours. And again, we'll see what is the grade of grade of hydronephrosis. And on the basis if it is the Society of Fetal Urology grade 1, 2, and 3, then in most of the cases there is no need of antibiotics. But in grade 3, 4, and 5, they need antibiotic prophylaxis. Two means in future.
Okay. Why do you want to wait for 48 hours before doing an ultrasound?
So because before 48 hours there is dehydration and low urine output, so that may not manifest the actual epidiameter. So we should do after 48 hours.
Yeah, perfectly right. So chemoprophylaxis is indicated if you are suspecting a lower tract obstruction, if prenatally it has been bilateral hydronephrosis, whatever grade, it's a solitary kidney with hydronephrosis of any grade, and epidiameter is more than 15 millimeter or SFU, grading more than 2 in the third trimester. So these are the indications for starting chemoprophylaxis. As you rightly said, for the first 48 hours, the neonate is dehydrated. This underestimates the degree of hydronephrosis. So you need to wait at least for 48 hours. I usually wait for about 5 days before doing an ultrasound. And you don't do a serum creatinine also initially, because within the first 48 hours, that reflects the maternal levels. Okay. So what are the areas when you would do an ultrasound earlier?
Sir, if there is a bilateral hydronephrosis.
Yes. 1. Second.
Solitary kidney.
Very good. Third.
There was evidence of anhydromnios or anhydromnios in the prenatal scan.
Yes, and suspected lower tract obstruction.
Lower tract obstruction, yes.
So when you suspect PU walls, it's bilateral hydronephrosis or a solitary kidney with hydronephrosis, especially if it is AP diameter is more than 15 millimeter or SFU grade more than 2. In the third trimester, you would go for an ultrasound earlier. Now, coming back to this case, the ultrasound was done on the 5th day. The right kidney, absolutely normal. Left kidney, no hydronephrosis seen. What next? Will you ask the child to come for, or parents to come for follow-up? Will you start chemoprophylaxis? Will you do an MCU? Will you do a renogram? And what would be your follow-up strategy?
The patient needs follow-up with the this sonography on the follow.
On?
Follow.
When?
At 3 months, sir.
At 3 months. Okay, why do you want to do an ultrasound again? Why do you want to do an ultrasound again? This ultrasound done on the 5th day, absolutely normal. Sonologist is reliable. See, postnatally getting such a scenario is very common, because if you look at all prenatally detected hydronephrosis, 70% of them don't end up require absolutely nothing. They subside on their own, or they don't require intervention. But you need to do an ultrasound, because you may get a recurrence of hydronephrosis in 15% of cases. Okay. Interestingly, 9 to 25% of the cases also have got reflux. Now, with this data in your hand, would you recommend an MCU for such patients to pick up reflux? If yes,
No.
why? If no, why?
So MCU not in the initial setting, because it's a difficult procedure to be done in a small child, unless the patient has hydronephrosis on a follow-up USG. I won't go for an MCUs. Or
Okay.
unless the patient develops a febrile febrile illness.
Correct, correct. So what should be the strategy for management of cases where you don't find a hydronephrosis on the first postnatal ultrasound, though the prenatal ultrasound mentioned hydronephrosis? USG should be done at 1 month and 3 months, at 4 weeks and 12 weeks. MCU is not recommended if both the ultrasounds are normal. And chemoprophylaxis is not recommended routinely. It is indicated only and only if the follow-up is not reliable. And even a urine routine should be done only if the infant is not well. Otherwise, the reason for that being, though literature mentions that 9 to 25% of the cases are having reflux, most of the time this reflux is very low-grade reflux and is clinically insignificant. Most of them never end up developing febrile UTI. So there is no need for giving chemoprophylaxis as such. But the follow-up should be done by ultrasound, which is done at 4 weeks and 12 weeks. Okay.
Yes, sir.
Second case, a prenatally detected male child with left side hydronephrosis, AP diameter 15 millimeter in the ultrasound done in the 3rd trimester presents to you. He is 1 month old now. The mother says absolutely fine. They have come to you only because the prenatal scan showed hydronephrosis. What would you do?
Ultrasound.
Yes, you would ask for an ultrasound. This is, then they present 3 ultrasound reports from 3 different centers done over 1 week. First center mentioned it as moderate, other gross, third mild hydronephrosis, and the AP diameter of the renal pelvis is 31 millimeter, 34 millimeter, and 27 millimeter, as mentioned by the different centers. Are these centers wrong in their assessment, or can you give me any reason why the AP diameter can fluctuate in different centers?
So it will depend upon if the patient has associated reflux. So that time,
if reflux is not present, then
maybe it's partially obstructed, so that's why there is variation in the AP diameter.
See, AP diameter depends on a lot of things. In even the amount of hydronephrosis or degree of hydronephrosis that is seen can vary depending upon 2 important things. One is the hydration of the child, and second is how much the bladder is full. In your clinical practice, you will come across lots of cases, especially in children, where the radiologist says ki bilateral mild hydronephrosis present. And if you read carefully, lower down they mention bladder is very full, distended. So a distended bladder can present mild hydronephrosis, and this can cause the variations in the hydronephrosis that is seen. So what are the precautions that need to be taken during ultrasound? The child should be well hydrated. The position does make a difference, but I think that's fine enough. I won't go into the details of it. Fullness of the bladder does make a difference, and the technique of measuring the AP diameter is very important. As per the guidelines which have been published by a multidisciplinary committee, the AP diameter should be measured in the transverse plane. It should be measured at the level of the hilum, and efforts should be made to obtain the measurements within the confines of the renal cortex and not try to include the extrarenal pelvic diameter because it can overestimate the AP diameter. Right? This was the sonography picture with the AP diameter being 27 millimeter. Now, why this 27 millimeter is important? Any of you has any idea about the landmark study about AP diameters by Dillon? She was a sonologist or pediatric urologist from Great Ormond Street, Britain. If you have any idea, fine. Otherwise, I would explain that to you.
No, sir. No, sir.
Because as far as I know, the recent edition of Campbell does not mention this particular aspect. See, what she found out was that if the AP diameter was more than 50 millimeter at 1 month and 3 months, 100% surgery was needed. But if it was less than 20 millimeter, only 3% ended up requiring surgery. While the figures varied from 80 to 20% depending upon how much was the degree of dilatation of the renal pelvis. And this was a landmark study which was published in 1998. And this paved the way for a lot of subsequent research which was done, which was followed up by Stephen Koff, also from US. The problem is this group between 20 to 50 millimeter, where the need for surgery can fluctuate very much. So, okay, we know that the child is 1 month old. AP diameter is 27 millimeter. The child is asymptomatic. There is physiological phimosis which is present. there has been no history suggestive of infection, and urine routine done is absolutely normal. Anything else you would like to do, or would you like to come to the nephrogram, or sorry, the renogram?
So it was unilateral.
Unilateral.
7 millimeters.
But the creatinine of the patient is normal.
Normal. 0.4.
Then we can go ahead with the renogram.
Okay. What would be the instructions you will give to the parents when they are going for the renogram, and what will you write in the chit or the letter, referral letter that you will send to the radionuclide department?
So the patient should be well hydrated, but before doing the scan, the bladder should not be full, sir.
That is easier said. What are the instructions you will give to the parents? He is a 1-month-old child. Yes, Manoj.
Renogram at 1 month will do, or will do at 3 months, sir, because at 3 months only there will be maturity of kidney, and we'll do at 3 months, sir.
Okay.
Not 1 month, I think.
Okay. Debatable, because most of the literature mentions between 4 to 8 to 12 weeks. So you can definitely defend yourself saying, I want to wait till the kidney is mature.
Yes.
But with 27 millimeter as AP diameter, getting a renogram at 4 weeks is also perfectly acceptable. गीते सर, आपको क्या लगता है?
Yes, sir. Doing a renogram with whatever the condition you have explained, it is indicated. The only the type of renogram may change. In immature kidney, particularly MAC3 scan is better than the DTP scan.
Right, Manoj. So now
or EC scan. So preferably
MAC3. So what are the instructions you will give to the parents, and what will be your referral sheet to the nuclear medicine department?
About the usage of the MAC3, and with the parents, we can discuss that the diuretic has to be given, plus about, because we are given the radio tracer, so the patient can have contrast allergy also. Plus, as we are given the radio tracer, the patient, we can counsel the parents regarding it.
Regarding what? Yes, sir, I am having quite difficulty in hearing you.
So regarding the radio tracer, we can counsel the patient that we are giving the radio tracer which has a radioactivity.
ये हो गया. You will ask the parents that, rather the mother, that you feed the child. See to it that he passes urine just before the study is done, but it's easier said than done. Most of the times it's not possible, or they cannot govern that. And as far as the nuclear medicine department is concerned, you are right, as Gite sir had mentioned, that you will ask for MAC3. If MAC3 is not available, what would be your choice?
DMSA.
DMSA nahi yaar. We are going for a diuretic renogram.
DTP or EC?
Huh?
DTP or EC?
DTPA or
EC?
EC?
Yes, EC scan.
EC. What is the full form of EC?
Diethylene 16.
It is ethylene dicysteine. So if you are given कि भाई हमारे पास MAC3 नहीं है, अब आपने कहा कि हमें या तो DTPA चाहिए या EC चाहिए, What would you say? हमारे पास दोनों है, आप कौन सा prefer करोगे? See, DTPA, the drawback is the background activity, and by and large, it is not indicated to use DTPA in infants. So EC is a better proposition. I think most of the radionuclide centers in India end up using EC rather than MAC3 because of the availability issues. The third thing that you would ask for, or rather I would prefer you to ask for from the nuclear medicine department, is what protocol would you like to follow? So what are the various protocols which are used for doing a diuretic renogram?
F-15, F0 and F+20.
Yeah, there is F+10 also. There are a lot of variations, but three standard things are F0, F-15 and F+20.
Yes, sir.
What would be your choice and why?
Okay, this case. We will do an F-15 in this case.
What is the dose of Lasix you will be using?
Child head-ons.
It is 1 milligram.
0.5 milligram per
0.5 milligram per kg. You can go to a maximum of 1 milligram per kg.
Okay.
Gite sir, what would be the right answer in such a scenario? Yani, what would be the choice? F0, F-15 or F+20?
Sir, it is depend upon the amount of hydronephrosis.
Okay.
If it is a gross hydronephrosis, then better to go for minus protocol. If it is mild to moderate hydronephrosis, and if there is no, again it is depend upon the amount of hydropelvis also.
Yes.
It is not only hydronephrosis. If there is a huge external pelvis or huge hydronephrosis, better to go for negative protocol. If it is a external pelvis but small, but the hydronephrosis again severe, then also negative protocol. For mild to moderate, F0 is better.
Prefer usually the F0 protocol.
Majority times, usually it is F0, but if the patient had a gross hydronephrosis, then better to go for negative protocol.
Okay. The renogram was done in this case, and this was, I don't have the picture of that renogram, but these were the findings. The differential function on the side, which was hydronephrotic, was 47.1%. T-half was more than 30 minutes, and the curve was an obstructed pattern. What next?
So the function is good and the system is obstructed. So the child will need the surgical treatment only.
Yasir, I again say I am not able to hear.
Are you interested in differential function or any other thing?
GFR, sir. But
So you are not asked
differential.
Because if
Yes.
one kidney is functioning 20%, opposite kidney is 80%. If one kidney is functioning 60%, opposite kidney differential function is 30%. So is that differential function which is the factor which decide the need of treatment or GFR?
GFR.
So you should have asked that GFR because that is not given in the slide.
Correct.
Yes.
He actually had disappeared, and he came quite late after 2 years and 3 months. In between, 1 or 2 ultrasounds also showed the same degree of hydronephrosis, and he came at the age of 2 years and 3 months. And this is the renogram now. I will make it as a slideshow, so probably you will be able to see it better.
It did not become slideshow.
Yeah, please.
It is still not slideshow.
It is still not slideshow. Any suggestions from your side how I can make it as a slideshow?
Just instead of making slideshow, make it 100% here. Instead of that 70% you have. Increase the size.
Increase sir, ये यहाँ से.
हाँ बस उसको परफेक्ट और थोड़ा छोटा कर दीजिए.
Yeah.
Or you can double click, just see.
नहीं हो
Sir,
रहा.
it is better to keep 70%. Whoever want to see, he can make zoom that slide and he can see.
Okay.
अगर मुझे देखना है तो मैं zoom करके देख सकता हूँ सर. 70% ही रखो.
Okay.
क्योंकि 100% कर दिया तो आउट ऑफ ये जाएगा वो. अपना क्या विजन से आउट ऑफ कुछ पार्ट चला जाएगा.
I can read the parameters if you want. The split function on the left side is 44.5%. T-half is 29.4%. And the curve of the left kidney is in green color. ये इसके images हैं और
So again, it's an obstructive pattern. The left side radio tracer has delayed drainage, as we can see in the last serial images that the right side is almost drained. The left side has a TF of around 29 minutes. So again, obstructed pattern, sir, of the left side, and also the kidney appears enlarged on the left hand side, slightly enlarged. The kidney count is around 30. Yeah.
it is 33,000 on the left side, 42,000 on the right side. Kidney count.
Yeah, actually, the right side movement. Sorry, sir. But the left side has delayed drainage. You can see that the arc is 29 minutes and the obstructive pattern is there, sir. In the images, you can see that the left side is the contrast radio trace is still there. Right side almost is gone in the last two.
Okay. So what would be your choice? You would, with a preserved function, you would still like to wait, or you would like to go for surgery?
So does the patient have fever in any history of UTI?
2 years, 3 months, the child is perfectly fine. The growth is perfectly normal. He has received his normal vaccination. His milestones are perfectly normal.
So we can wait conservative management for this patient.
Manoj, your thoughts?
So GFR is still more than 40, and the curve is I think 3A or 3B. So at this age, in 2 years, means it did not become worse. So at this point, we can wait, and we'll follow up.
Yeah. When would you repeat a renogram during follow-up?
During follow-up, we'll ask the mother or the parent that is there any palpable lump, any history of fever, any UTI, means any hematuria. Then they will come back, or 6 monthly we'll follow up.
Okay. When will you repeat the renogram?
6 months. 6 months. After 6 months.
Too early, I think.
गीते सर, गौरंग सर, आपके क्या व्यूज हैं इस पे?
Yeah, if we are doing, if you are waiting for a conservative management, I will usually go for a sonography, and that also to the same sonologist who will be doing sonography, and I'll tell them to repeat every 3 months. So compare it. If there is any hydronephrosis or other clinical symptomatology is there, again go for a reenogram or go and do the.
Gite sir, Pankaj sir.
Appearance of symptoms, increase in hydronephrosis, decrease in cortical thickness, and approximately 10% difference, 10% decrease in renal function conjugated to
Yes.
two renograms. That will be the indications for go ahead in this patient conservative treatment. But we have to observe this patient very carefully by doing periodic ultrasound 3 monthly. And I usually prefer to do a DTP or whatever renogram required after the age 6 months. 6 monthly, 6 months.
Yeah. Sir,
it may be slightly early, but if my ultrasound suggests you the need of renogram, I will go at 6 months. If it doesn't show, I will go for 1 year.
So I think, sir, we'll stop this particular case at this point. This child is still under follow-up. His function is still preserved, and he has still not needed surgery. He is, I think, around 6 years old now. A third case, a 3-month-old male child, history of having hydronephrosis on the left side. Ultrasound done at 3 months shows an AP diameter of 23 millimeter, and the sonologist says that there is significant calyceal dilatation and the urine routine is normal. I will straight away come to the point. This is the renogram which has been done. It's a MAC3 renogram.
Yeah, one of you please answer or read the renogram so that we can finish all the cases, you know.
Correct.
Yasi, Rogers, Manoj. Rogers, you may be wrong also, don't worry.
Yes, sir. So there is uptake of the radio tracer on both sides. The
Just I will show you both the films. You can have a look at these also.
Yes, sir. So these are the serial films of a renogram MAC3 protocol, in which we can see radio tracer uptake on both sides. The kidneys appear normal in dimensions. There is
there is delayed contrast excretion on both the sides.
The half of the second kidney is not good. The left kidney is not good. So the left kidney shows delayed contrast radio tracer excretion as compared to the right side. And the T half, however, the left side T half is not mentioned.
Okay.
Right. Fair enough. And whatever you are able to see because of the. So at this particular point, what would be your further strategy of management and your reasons for that particular strategy?
And so again, in this case,
let me ask you, will you keep the child on chemoprophylaxis?
There is no fever and hydronephrosis is however severe. So, so there is no history of UTI. So at present, we will not start chemoprophylaxis.
Right. Second question: would you ask for a circumcision as a prophylaxis against chances of developing infection?
Not at 3 months, sir. We will allow for the physiological part. After 2 years, if not, then only. Not at 3 months. Unless the child has severe ballooning of preputial skin, we explain the mother just to retract the skin and clean it and do the wait for the physiological phimosis to settle by 2 years.
You would be following up with ultrasound. What
Yes,
would be the frequency of repeating the ultrasound, and how long would you keep the child under follow-up?
So 3 monthly scans initially, and and we'll follow it up at least till 2 years, unless there is a rapid progression, then we will have to intervene.
The hydronephrosis remains stable. Till how long would you follow up the child?
So till 5 years, sir, I think 5 years.
6 years.
6 years, okay, 6 years. For the mature kidney function, yes, sir.
Right. And if the as Gite sir had mentioned, that if it shows any worsening of hydronephrosis on ultrasound, you would do a renogram earlier, otherwise at 1 year.
Yes, sir.
Okay, we come to the next child. He's a 7-year-old child. He was seen in 2013 with an incidentally detected left-sided hydronephrosis. Okay. This was the AP diameter that time, 40 millimeter. The renogram done in 2013, whatever reports were available with him, I am just mentioning it. The left kidney showed a 46.2% function. It was an obstructed pattern and T-half was more than 26 minutes. The renogram was done in 2015 again. The ultrasound was also done at that time. The AP diameter still remained 40 millimeter. The renogram shows a differential function on the left side, which is about 40, it is 48.2%. And this is the pattern which is seen. This was in 2015, then 2016. The function is 46.1%. The pattern remains nearly better. 2018, it is again 47.5% or 48.5%. See, the reason I put up these serial renograms, and I think this point was well brought out by Gite sir, was that if the function remains good, there is no deterioration of function. The difference is not more than 10%. The hydronephrosis does not show deterioration. There is no parenchymal thinning. There is no gross enlargement of the kidney in serial sonographies. And the child remains asymptomatic. He can be followed up by sonography and renogram. And even if the AP diameter is 40 millimeter, the child can be managed conservatively without surgical intervention. This child has got selected in the under 19 or under 16 cricket team from Maharashtra state. Coming to the next case, a 3-month-old male child brought with history of bilateral hydronephrosis in prenatal scans. They presented at 3 months to me because the pediatrician had advised them to seek surgical opinion at the age of 3 months. At that particular point of time, the parenchymal thickness was about 5 millimeter on the right side and 4 millimeter on the left side. And the AP diameter was 27 millimeter on the right side and 35 millimeter on the left side. Okay. This is the renogram.
Yeah, someone has asked, yeah, how much you will follow up in the earlier case?
Sir, I would have preferred stopping it. The problem was with the child because if 3 sonographies are doing so well and 3 renograms are not showing any deterioration of renal function, one could have as well stopped and followed it up much more infrequently. The worry here was because he is a cricket player and wherever he goes for some physical fitness tests and this and that, the parents are extremely apprehensive and hence they come and say ki nahi sir ek karke confirm karna hai so that his cricketing career is not affected.
Correct. So because of apprehension, you have continued.
Yes.
But otherwise, I think that till puberty, whatever the changes, 6 years is right. But even up to puberty, you can just follow. After that, everything is okay. you can tell them that now,
So my experience has been that some of these children who remain stable till the age of about 6 or 7 years, when there is this growth spurt, occasionally I have seen in some of them the renal function deteriorating.
Yeah, so that is what I'm saying. Till puberty, you should follow. Yeah, let's continue with this case.
So the differential function is left side 51%, right side 49%. T half is more than 20 minutes on both the sides. And these are the serial films. Ojas, what will you do?
So what is the
Bilateral
age?
hydronephrosis. So the differential function is not very reliable parameter.
So what is
Obstructed
the
pattern is present on both the sides.
So age again, sir? Age was
3 months.
Age was 3 months.
3 months old. Bilateral hydronephrosis, both obstructed pattern. So in this case, so any history of fever, any
Absolutely asymptomatic. Absolutely asymptomatic.
So in this case, creatinine is normal.
Yes. First question, will you do MCU in such a case?
So again, this patient first, I would like to do serial ultrasonographies. If there is increase in the hydronephrosis, then we would consider for MCU.
You will consider for increase in hydronephrosis, you will consider?
For MCU, sir. Because so in the patient is a 3-month-old child, so there can be also issues with he being constipated, and those issues could also lead to bilateral hydronephrosis. So I will do a serial sonography. If there is worsening, then I would like to do a micturating cystography.
Gite sir, as an examiner, what would be your take on the need for MCU in bilateral hydronephrosis?
Bilateral associated vesico-ureteric reflux is comparatively high. That is near about 30 to 50%. That's what I remember. So, in spite of having asymptomatic patient, in such situation, better to go for at least one baseline VCUG. That's what we were following. Guidelines wise, I don't know. So please, आपको कुछ change of opinion है तो बोलिए.
The guidelines which have been given, and the chapter in the recent edition of Campbell, I think, is written by Hendron, if I remember correctly. So his studies and his literature and what he had proposed was that if the AP diameter is more than 30 millimeter or 35 millimeter, you do an VCOG so that you rule out reflux. But if somebody says that in the absence of infection, in the absence of dilated ureters, and the sonography being reliable, they would avoid doing a VCOG. I think they would still be justified, because in UK, by and large, they are very hesitant, and in European side, they are a bit hesitant when it comes to doing a VCOG because it's an invasive procedure. If you ask me, what I follow is, if there is no infection and there is no hydroureter and the kidneys look normal, there is no scarring which is seen, and the cortical pattern is good on sonography, I don't do a VCOG. It's an invasive procedure. But you will have to check up, because I have read the recent edition quite long back when it had just come in the market. Whether the recent edition mentions the role of VCOG in this particular category. Because the original article by Hendron did mention the indication for VCOG in bilateral hydronephrosis, especially if it is AP diameter is more than 30 millimeter.
Okay, but otherwise people are, if there is, as you said very rightly, if there is no infection, if there is no deterioration of any function, we are hesitant to do because it is an invasive procedure. And if there is no infection, there are all chances that we will introduce infection.
Absolutely, sir. So this child was kept under follow-up on sonography. His function has remained stable, and in fact, his curves are getting better over a period of time.
Yeah.
Hydronephrosis is also shrinking. So the question comes is, when would you operate such child? Is if he is symptomatic, the function is less than 40%, there is a progressive decrease in function, and there is a drop of more than 10% in the renal function. Though if you ask me personally, according to me, this T-half is a useless parameter as far as determining the need for obstruction is concerned. Probably, if not today, after 5 to 10 years, this will disappear. And you need to look at more different parameters and the cortical transit time in deciding the need for surgery in cases where the function is quite good. Sir, I think I have tried to cover few aspects of prenatally detected UJ-like obstruction.
Yeah.
Any queries from the side of the students before we go further?
Are there any questions in these 5 cases?
So we'll go for F0 only in this, or protocol, sir? F0 or
there is F0, F-15 and F+20 protocol. The dose of Lasix is 0.5 to 1 milligram per kg. The dose of radionuclide that you are using is 0.5 millicurie to 1 millicurie.
0.5 to 1 millicurie total or per kg?
Total. And the ideal way to do a renogram as per the guidelines by the European Society of Radionuclide Medicine is the child should be well hydrated with an IV drip. These are the ideal things which nobody follows, and their subsequent protocols by the European Nuclear Medicine also says that there is no need for an IV line, but ideal, if you ask, is an IV line for hydration, an infant feeding tube in the bladder so that there is continuous bladder drainage, and preferably they follow the F0 protocol.
Okay.
The reason is they don't maintain an IV line. You take a single prick, you push both the things at the same time, the radionuclide as well as the Lasix, and that's it. Any questions? Any further questions before I move to the last 2 cases?
Someone was asking about the surgery, but it is already written here, the indications of pilotus. So these are the indications for the surgery.
Yeah.
Amida, I think, has asked this question. Okay, I think we go ahead.
Right. A 3-year-old Muslim boy presented with pain in abdomen 3 months. Since last 3 months, the pain is dull, vague. He is not able to localize the pain to a particular area. There is absolutely no other positive history, but he has undergone a religious circumcision. He has come with these investigations, which show that the urine is normal, the biochemistry is mentioned here, and sonography shows a grossly enlarged left kidney. It's the left kidney with gross hydronephrosis and hydroureter, causing significant parenchymal thinning. The maximum parenchymal thickness which could be appreciated in some parts of the kidney was 4 millimeter, and the diameter of the lower ureter was 27 millimeters. Okay.
Right side?
Left side. Left side.
No,
Left side.
What about right side, sir? Right side is
absolutely normal.
Okay. So 3-year-old. No, sir. In this case, we would like to do a voiding cystourethrogram because there is obstruction of the entire ureter till the pelvis, and there is gross hydronephrosis.
Yes.
So we like to do a voiding cystourethrogram.
This is the voiding cystourethrogram. Okay. Shall I increase this? You will get a better idea, I think.
Yeah. Okay. So we can see
There is normal. There is no reflux. There is no dilated posterior. I think bladder neck has not opened.
This particular film does not show the urethra, but yes, there was no reflux. Okay, now what next?
so this is the scout film. The you can see the serial images of it, or this is the scout film?
No, this is the only one which I have with me. But take my word, all other films, they show the bladder empties completely.
Bladder empties completely. Okay.
Yes,
And there is no
yes.
reflux.
No reflux.
So then in that case, we would do a creat was normal, no 0.7.
Yeah, 0.7.
Then
Ojas, will you like to do some investigation or you want to?
CT IVU, sir. I would like to know about.
I am amazed, Janet. This I have heard in a lot of talks and other things. Why do you want to do a CT IVU?
So for she's a grossly hydronephrotic kidney. No, sir. No, CT scan. So, yes, sir.
The ultrasound shows left-sided gross hydronephrosis with parenchymal thinning. There is marked hydroureter. The diameter of the lower ureter is 27 millimeter. The VCUG is not showing any reflux. Now, what is the probable diagnosis?
Obstructed megaureter on the left.
Absolutely fine. So there is a megaureter, that is certain. You have ruled out reflux, right? Now that leaves us out of the 4 different types. What are the different types of megaureter?
Primary obstructive megaureter. Then this
Fluxing megaureter. Then both obstruction and refluxing, and then none.
Non-obstructed. Which is the rarest of them and which is the commonest of these?
So refluxing is common, sir.
Okay, and which is the rarest?
Non-obstructing, non-refluxing is the rarest.
Obstructed with refluxing is the rarest.
Okay, obstructed with refluxing.
And if you rule out reflux, the non-obstructed variety is the commonest.
Okay.
Okay.
So now you are dealing with megaureter which does not show reflux. So that leaves you with only 2 possibilities. Either it is an obstructed megaureter or it is a non-obstructed megaureter. Isn't it? Now, yes, considering the fact that the ultrasound is showing marked thinning of the renal parenchyma, what is the more common possibility?
Obstructed, sir.
Exactly. Now, yes, what do you want to know? You want to do a CT IVU or you want to do a renogram?
Renogram to know the function.
Exactly.
And,
yes, CT will only give you an anatomical detail. With such a bad parenchymal thinning, the chances that it is going to pick up some contrast and excrete, because it exposes the child to unnecessary radiation. So renogram was done. These are serial images of the renogram.
So right shows prompt excretion, left there is hardly any uptake and no excretion at all. And there are many. So the left has minimal uptake of the radiotracer and no excretion. Right is complete excretion and the normal curve.
Yes.
There is obstructed pattern of curve.
See, when there is so much decrease in function that it is something around 30% that they have mentioned, the pattern of obstruction becomes immaterial. 20%, 25%, 30%, this kidney is already affected. right? So the percentage function that has been mentioned here is 31%. And you are right, it is showing very poor uptake. So what would be your plan of action? Which surgery will you plan? How will you plan? What are the precautions you will take during surgery? And after that, we will come to the post-op care and follow-up. Will you intervene? First question.
Yes, sir.
Yes. So what surgery do you have in your mind?
Ureteric reimplantation.
Which type of ureteric implant would you like to go for?
The non-refluxing intravesical.
Okay. How do you classify ureteric reimplantation surgeries?
Extravesical and intravesical. Extravesical is the Lisch-Gregoire. Intravesical, we have.
Ojas, you seem to have assisted a lot of renal transplants.
Yes, sir.
Yes. In a megaureter of this magnitude, Lisch-Gregoire would not be a very preferred surgical modality. Okay, so extravesical and intravesical approach. Can you mention the different types of ureteric reimplants?
Leadbetter
Lisch-Gregoire is
Politano.
one.
Leadbetter Politano.
Yes.
Then
the Cohen's means there is cross trigonal in case of biceps.
Yes, Cohen's is there.
And then in case of ureter, we have to placate the ureter, start plication, and
that will come later. What are the things in surgery will come later.
Okay.
So this child, you have explained the need for reimplantation. You keep the child NBM. Let me go stepwise. Anesthesia has been given. Now what next?
So before that, I will have to ensure that the urine culture is sterile. So that would be one.
Sterile.
Yeah.
Agreed. It is sterile.
Okay. First, I would like to do cystoscopy.
Good.
And evaluate the lower tract and do a retrograde pyelogram to confirm the finding and
Perfectly
then proceed
fine.
for the surgery. Yes, sir. Then proceed accordingly.
Yes. You have done a RGP on the left side. It shows a narrowing about 1 centimeter above the bladder. And after that, there is marked dilatation and tortuosity of the ureter.
We will go for a ureteric reimplantation.
How will you go? Mention the steps. पहले क्या करोगे, फिर क्या करोगे?
Patient in a supine position, lower midline vertical incision, or a Gibson's incision would be used.
Midline or Gibson?
Gibson's would be better. Gibson's incision.
Correct.
Then the peritoneum dissected of medially, extraperitoneal dissection carried along. The common and the external iliacs, the common iliac is identified and the ureter is traced. Then the distal is the bladder is then mobilized up and
why would you need to mobilize the bladder if you have gone extravesically?
Sir, if in case we require to prevent tension when we do a reimplantation, Uh,
Hello?
Ojas,
yes,
where
sir.
you are going to reimplant? First tell us. Which surgery you are planning?
We are planning in this case intravesical, extravesical non-refluxing implantation, sir.
So which one?
So one of your aspects of doing a reimplantation would be to prevent reflux. So you want a non-refluxing. The
Yes, sir.
other issue that you are likely to face is the market dilatation of the ureter. And as Manoj had mentioned, would you have an idea of plication in your mind or tailoring of the ureter in your mind?
Yes, sir. Yes, sir. Yes, sir.
So what are the ways in which you can decrease the diameter of the ureter?
So there are two methods of the plication. One is the star plication and other is the Konchesky plication.
Kalinski's.
Kalinski's plication.
Yes.
The difference is in the plication that in the star plication, we would in one we would basically take the just plicate it around the ureter. After putting the ureter catheter or the rubber catheter, we will basically mark the ureter, the redundant ureter, and we will after plication we will hold it over the ureter. And in the second one, sir, there it's a
One is you fold it, and in the other one you don't fold it, and the other thing is that you have to tailor it. Now, why do you
yes,
want to decrease the diameter of the ureter? क्या फर्क पड़ता है यार इतना सब मेहनत करने का डायरेक्टली इम्प्लांट कर दो.
if we basically decrease the studies show that if we decrease the diameter, there are chances of the peristalsis after this.
नहीं, you see on table peristalsis अच्छा है, तो क्यों डिक्रीज करना है यार? You know, if you read that, the chances of success following a reimplantation surgery are nearly 98%. But the moment you end up tailoring the ureter or doing plication, the success rate comes down to 80 to 88%, which is a drastic decrease. But still, books mention that you need to decrease the diameter of the ureter. Why?
There are also decreased chances of the infection and stone formation.
नहीं यार, stone formation, no.
Oh, that 1:5, 1:3 कुछ ratio है क्या है वो?
Yes.
Yes, sir. It is the tunnel length by the diameter of the ureter, sir.
Correct. So this is what Gite sir is asking. Ki when you decrease the diameter, the tunnel that you make will be of a lesser length.
Okay.
So which is the minimum? What should be the ideal length to diameter ratio?
5:1.
5:1.
And minimum kitna chahiye to prevent reflux?
3:1. The minimum
Very
is
correct.
3:1.
Very
Yes, sir.
correct. Right. Okay. अभी आपने बहुत अच्छा this is something which is a matter of personal choice whether you would like to go for an intravesical or an extravesical approach. I by and large never tailor the ureter. I might, if need be, if it is a unilateral surgery, I might do a psoas hitch, so that gives me a greater length of the bladder through which I can make a tunnel, and I end up making what is called as a nipple wall like of ureteric orifice. And in the last 20 years, I never had any reason to change my pattern, but I am not fond of tailoring. But in exam, I think you are perfectly justified in saying tailoring or plication, whatever you want. Now, once you have done a good ureteric reimplantation, what are the other things that you will take care? Let me ask you specifically, will you put in a DJ? Will you put in
Yes,
a
sir.
periureteral catheter? Will you put an SPC? And if at all you are going to put all these tubes, what will be the way in which you are going to remove one by one?
I will like put the DJ stand as the catheter.
So all three, digestion, SPC, and a catheter. First would come out would be a per-urethral catheter. Then the SPC, and last would be the digestion.
And when will you remove the drain? Or you will not keep the drain?
So we'll keep a drain also. So drain, SPC, per-urethral catheter, and digestion. The first would come out is the per-urethral catheter.
How many days?
So 3 to 5 days or 3 days or 48 hours, 48 hours, 48 to 72 hours.
Then next.
I never would advocate putting a periurethral catheter, but I don't know what is the practice at other places. In a male child, a PUC is as far as possible avoidable. You can keep an SPC 12 French Foley in a 3-year-old child, that would be good enough. But fair enough, if it's a system which is followed in your institute, you can very well say, sir, this is what I have seen in our institute. You have taken the patient out. The surgery is over at 12. The sister calls you up in the night at 8 o'clock saying कि sir, urine का color बहुत red लग रहा है.
Yasir, what you will do now?
If the SPC plus the catheter is there, then we can basically start with the irrigation.
The catheter has not got blocked. Color red.
Just maintain hydration for now. The color would be red because there is an anastomosis. So it will be red. Maintain hydration and observe. The catheter gets blocked. The gentle flush maybe could be attempted. Otherwise, no need. Just continue with hydration.
Yeah, very good answer, because most of the times following ureteric reimplantation, you will observe hematuria anything from 48 hours to 96 hours also at times.
Yes, sir.
And it appears reddish, more reddish because of dehydration.
Yes.
Yes, sir. So then first would come out as a periurethral catheter. Then I would like to clamp the SPC and then observe for 24 hours whether the drain output increases. So the if the drain output doesn't increase, then we can plan for drain removal maybe at 7 to 10 days. Then SPC would come out with the remaining clamp, then it would come out later, and degestant after 4 to 6 weeks.
Fair enough. Sir, anything else to discuss?
No, I think he has answered quite well.
Quite well, really well. So we come to the last, I think one more case after this. Sir, we will take one more case only and then stop, I think. That's the last case.
Okay.
A 7-year-old girl. A 7-year-old girl presented with complaints of incontinence of urine and wetting of underpants in day as well as in night time since the last 4 years. I asked the mother, she feels that probably the girl was leaking even before that, but she is not so sure about it. But for the last 4 years, they have realized. So they kept on trying something or the other, but nothing has worked. Clinical examination is absolutely normal, except the fact that if you look at the genitalia, the urine keeps on trickling. You are able to see the trickle of the urine from the genital area. 7-year-old girl, not very cooperative, especially in the OPD. So this is all that I could pick up. The urine examination was normal. Her creatinine was normal. The biochemical parameters were normal. What next?
So this is more like an ectopic ureter. So
Ultrasound.
Ultrasound.
Yes, you are right in your thought process that it is likely to be an ectopic ureter. Ultrasound, this is the report, I will read it for you. Left kidney, the size is 60 by 36 millimeter. The echogenicity is normal. CMD is well maintained. The upper pole calyx is dilated, and the parenchymal thickness is normal. There is grade 1 hydronephrosis, and the ureter is dilated in its entire length. The diameter at the UVJ is ranging from 3 to 5 millimeters. The right kidney is 70 by 27 millimeter in size. Echogenicity and CMD normal. Mild hydronephrosis is present. There is dilatation of the ureter, which seems to be dilated in its entire extent. The diameter at the ureterovesical junction is about 6 millimeter, with a suspicion that there is ectopic opening of the ureter, because it is not seen to be opening at the bladder. The bladder in the pre-void state is showing 100 ml of urine. Post-void, it is 5 ml. Okay.
Yes, sir.
What next?
So, in this case, we would do a CTI view. So I would like to know the exact anatomy. So CTI view, because this is more like an ectopic ureter with duplicated system with.
Now, in an ectopic ureter, what are your worries? One, you will have to make the diagnosis. Second, you will have to know whether it is a duplicated system or not. And third,
Yes,
you
sir.
are interested in knowing whether there is presence of reflux or not.
Yes, sir.
Well, I by and large am quite averse to getting a CT IVU done in children. What I had done was I did an MCU. So this is the MCU.
No reflux, bladder appears. And this is the first, again, so this is the first film or all the films like that?
Just see whether I have. Yeah, I will show you the other films also.
Okay, there is reflux. There is bilateral reflux, left
Yes.
more than right. And
I will show you further film. It is emptying also completely.
Okay. One of the ureter is seeing opening into the lower part below the bladder neck on the left hand side, and we can see that the left system, there is bilateral vesico-ureteric reflux. Left more than right. Left would be grade 3 or 4, whereas right would be grade 2, sir. Grade 2. We can see that on the left hand side, the ureteric opening is seen below the bladder neck. However, the bladder is emptying entirely. So this suggests that there is bilateral vesico-ureteric reflux with an ectopic ureter opening. We can see that the opening is below the bladder neck.
Okay.
It is
now,
going.
I had done an IVU also. CT was not done, but an IVU was done. So this is at 30 minutes. And this is the entire IVU film.
Minutes, 30 minutes both. So right side is still going, left side. So right side, both have delayed drainage actually.
No, if you look at the 10-minute film, there is good concentration on both the sides. They are excreting also well.
Yeah.
But the right side is showing more hydronephrosis as compared to the left side.
And mainly see the lower ureter.
Yes, and there is hydroureter.
Both the ureters are seen to be draining this below the bladder neck.
Yes. In this film, 10-minute film, you feel they are going down.
Yeah.
Yes, sir.
Good, good, very well picked up. So what next? You have an MCO, you have an IVU. What would you do next?
First, the renograms. I like to know the function as well, because the bilateral reflux
Fair
is there.
enough.
So I like to.
You are right, but the place where I work, and at that particular point of time, the nearest renogram available is 300 kilometers away. So the logistic and socio-economic factors prevent us from getting a renogram done in some of these cases. So it was
Yeah,
not.
Yes,
one logical question: if the IVP is showing good function on both the sides, then I think in your cases we can always keep renogram, because then
Okay.
renogram is only to, or if you want to do, then do DMSA scan to rule
Yes.
out scarring.
Okay.
Correct. So what next?
Cystoscopy.
Right. And I will show you the cystoscopy. I will stop sharing this slideshow and I will show you the cystoscopy thing. Just a minute. नहीं हो रहा है. Are you able to see the cystoscopy?
No, sir. No, sir. Can't see.
Just a second. Yeah. The cystoscopy was done using a 6 by 7.5 French scope. This is the trigonal area. The trigone is not seen to be developed. It's a wide open bladder neck, and on the right hand side of your screen, by the side of the bladder neck, you are able to see one more opening.
Yes, sir.
So that is the ectopic ureter opening on the left side. You are able to see that?
Yes, sir. Yes, sir.
Yes, sir.
And this ureteroscope has entered over there easily. You are seeing the other opening also?
Yes, sir.
Yes, sir.
Yes. I have entered that also. So you have a situation where you have a 7-year-old girl with both ureters opening ectopically. What would you do now?
Manoj, you have picked up the diagnosis.
Yes.
Yes, sir.
So it's not a duplicated system, no, but I just wanted to know about that. Is it a duplicated system? Like,
I think there is no duplication on either side.
There is no duplication.
You have to plan surgery only, sir, for this.
Yes.
Bilateral ureteric reimplantation only, sir.
What are the issues which come to your mind?
Okay. One is the trigonal area is not developed. Second thing is
Ureter goes under neck, deep down.
No, the question number one, what is the surgery normally you do for reimplantation of ureter? How much ureter you decide? Whether you remove the whole ureter or you leave behind some ureter? When normal, in the normal refluxing ureter,
leave behind some ureter.
you leave behind some ureter. If it is a refluxing ureter,
refluxing, no, not for refluxing, no.
So just you will not leave behind the ureter and you will dissect right till the bladder neck.
now this is on both the sides. It must be crossing the sphincter.
Yeah.
And you, so what now? So this is a catch Dr. Sharma is asking you. In this case, what you will like to do?
The reimplantation, but the dissection should not be done up to the bladder neck.
Was a simple question here. No. Do you want to disturb the trigone and bladder neck?
No, sir.
No, sir.
Because that will interfere with the incontinence again. The patient has come for incontinence. So this
because if it is distal to the bladder neck, then why that it should be refluxing? If it is really distal to the bladder neck, why it should be refluxing?
That should be refluxing when the patient is voiding. So we saw in the films that when the patient was voiding, that time it was refluxing. It was not refluxing the initial part. So that is the reason. So because
there is the crux. Then is it necessary to dissect all the ureter right up to the opening across the trigone?
Okay. Yes, sir. Yes, sir.
Yes or no? Is it
no, sir.
necessary or yes or no?
No, sir. The dissection should not be carried to, up to the neck, sir.
If same thing is happening when it is an intravesical opening, the opening
his voice is that his internet is not audible proper. So Sharma, you only explain that.
See the at this particular point, what Gite sir, सर गीते सर आपकी आवाज कट रही है.
जी सर आप बोल दो सर, नेटवर्क का इश्यू है, आप बोल दीजिए.
See, what sir is asking is very important question, that if there was reflux with both the ureters opening in the bladder and there is reflux with both ureters opening outside the bladder. Now, when the ureters are opening in the bladder, you will dissect it right till the ureterovesical junction and disconnect it. You will not like to keep a refluxing stump. But
yes,
if the ureter is opening ectopically, then if you try to dissect much beyond the bladder neck area, you are going to cause permanent incontinence to the child.
Yes,
so in an ectopic ureter, you should dissect it only till the bladder and leave it. Okay. Now there are a couple of more issues in this particular patient. Both the ureters are opening in the urethra. They are not opening in the bladder. So you are worried whether it is a defunctionalized system. But if you look carefully at the cystogram, it's a good capacity bladder. Even on ultrasound, it showed a 100 ml capacity. And if you look at the cystogram, it can easily fill up to 150 grams, 150 ml also. So the capacity is good. Now, your worry is, one, how much to dissect. That is clear that you will dissect till the bladder. Second, the reimplantation that you will try to make would be non-refluxing. That's fine. Third issue will be whether the girl will be continent. Because if you look at the anatomy of the way the musculature develops, there is a muscle fibers which are coming from the ureter, they form the trigone and they go right into the urethra. If you remember reading all this from, I think the one of the very good books which mentions this anatomical description is Smith's textbook of urology. In very short, I think it's a single paragraph which mentions it very well. So your worry is how much continence will she develop? So do you want to do an additional procedure which will take care of her continence also along with reimplantation? This is another question. And when you want to do reimplantation, obviously it will have to be an extravesical reimplantation. Would you like to do a bilateral extravesical ureteric reimplantation at the same time? Right? Now, these are cases which are by and large very rare. You hardly come across such cases. This is the first case which I also saw in my life. What I did, the way I looked at it was the bladder is having good capacity. The child was not wearing a pad. She's a 7-year-old child, sharp enough. She was not wearing a pad all the time, which means that by means of contraction of her pelvic floor muscles, she was able to achieve some degree of continence. Now, ideally, bilateral extravesical ureteric reimplantation is not done. Why it is not done? Because if you dissect the bladder too much, in 10% of the cases, you would end up denervating the bladder to such an extent that the bladder loses its ability to contract. But this is true if you are going to dissect it right till the trigone. If you are going to dissect it only up to the level close to the bladder without causing much mobilization of the bladder, I think you do not denervate the bladder much. So I did a bilateral extravesical ureteric reimplantation and I kept an SPC for 2 to 3 weeks. So that if at all certain degree of hypotonicity has set in, the bladder gets adequate rest and gains its tones. At the end of 3 weeks, when I clamped the SPC, she was able to void and empty her bladder completely. So I removed the SPC, the DJs were in place. I put the child on imipramine. And when she came back for removal of DJ after 1 month, she said that occasionally she is incontinent in the night, but otherwise she is having good continence. And then I removed the DJ. She has come for follow-up twice after that. And she is reasonably dry except for occasional periods of bedwetting that happen in the night time. This is a very rare case. So I thought I would I had a cystoscopy also of this patient recorded. So I thought of presenting it.
Very good collection.
So, sir, I think that's all from my side. Any questions from the student side? I would be most happy. Any expert comments, sir, from Gaurang sir, Hiren
Yes,
sir,
no,
Gite sir?
all the cases are very good, and we have shown many cases which are showing actual obstruction in the PUJ and go ahead with the surgery. But your cases, these are the real cases where we have a dilemma whether to operate or not to operate. And I'm sure that all the students who have attended today, they have understood when to operate and when not to operate.
I think it was a academic feast, sir, pediatric academic feast.
Yeah.
Superb collection of cases and such good discussion. I think those who have not attended, they can see it on YouTube because they are such important cases.
No, everyone see today we have got almost 900 subscribers and many of them are going through all this clinic because only problem is exams are very nearby. The MCH exams are in first week of July and I think DNB is in first 10th or I think 20th of
June 22nd June 22nd.
So they are quite under tension to read. But you just tell your colleague to go through all these lectures. And in Mumbai, those who are there, please attend mock exam. Don't worry. Don't think that if you can't answer, what will happen. Don't worry. Okay? Good. Gyanendra, it was really a feast, and for years, people are going to watch this session, I'm sure.
Excellent collection of rare cases, and it covers majority of the pediatric urology, as well as good discussion.
Sir, reflux
And,
and tube walls भी बहुत थे, but अभी then 2 hours is inadequate, sir. वो बहुत लंबा जाता है. Reflux becomes too lengthy.
Yes, now we know, we are realizing that how to improvise. So next session, when we are going to have practical exam. So after they finish their theory, we will have practical exams. I mean, discussion, and then again we will have the third or fourth session or season. So we know how to improvise and how to make them study and understand. So thank you very much.
Sir.
Yeah. Bolo.
I have placed one good article about antenatal hydronephrosis and postnatal follow-up on MUS Media update just now.
Okay.
It is a 2020 article, and there is answer to that question: VCUG is to be done or not to be done in bilateral hydronephrosis. In that particular
article post किया आपने सर बताइए, क्योंकि I am not part of that group.
मैं सर आपको भेजता हूँ सर, ठीक लगा मुझे इसलिए मैंने भेजा है. तो एक बार पढ़ने में हर्ज नहीं.
Yes.
All varieties of different situations they have discussed in that, and it is from the African Journal of Urology.
Okay.
Thank you, sir.
Fine. Then all the best to all the students.
Yes.
Those who are appearing. So we will be seeing you after.
All the best, and all three of them answered quite well today.
Yes.
Thank you, sir. Thank you,
All
sir.
the best, everybody.
All the
Thank you,
best.
sir.
Thank you.
Thank you, Gaurang sir, Gyanendra sir, Gite sir. Good night.
Good night. Good night.
Good night.
Good night, sir.
Thank you, sir.